Let's talk about when you think a patient has cellulitis. Only they don't. Hello and welcome to this week's Urgent Bite, brought to you by the Royal New Zealand College of Urgent Care. My name is Guy Melrose and today we're taking a quick look at cellulitis mimics. Cellulitis is a very common presentation through urgent care clinics. Back in May of last year, we spoke with Dr Justin Morgenstern about the use of IV antibiotics for the management of cellulitis and how they are often used when orals would have been sufficient. We talked about how failure to respond to orals is a reason many will opt for IV therapy, but in fact the failure to respond might have been due to incorrect choice of agent, or not enough time has been given for adequate response. But it might also be because the diagnosis of cellulitis was incorrect in the first place. So I asked Dr Amanda Oakley, consultant dermatologist at Waikato Hospital, an Adjunct Associate Professor at Auckland University, and the founder of Dermnet, to tell me the sorts of things we need to think about that could mimic a cellulitis.
Let's start with how we diagnose cellulitis. Classically, that's a fever and rigors occurring, followed by the appearance of a painful rash and swelling in a localized area. The patient is not well. The dermatologist gets called in sometimes a few weeks later to say that the cellulitis hasn't settled, and we discover that those symptoms weren't actually present in the first place. And the other thing that's sometimes a surprise to me is bilateral red, swollen, painful skin. And that's rarely cellulitis. It could be, but it's not usually. So the conditions that we most commonly see misdiagnosed or mismanaged can accompany cellulitis, and then that's a problem. If you've got damaged skin, it can become infected. So the two situations are lipodermatosclerosis and contact dermatitis, or any kind of dermatitis, come to that. So lipodermatosclerosis is a form of venous disease, and it has acute and chronic forms. So the acute lipodermatosclerosis presents as an acute or subacute development of red, swollen, painful areas. Now these are usually the lower legs, and it is usually bilateral, but it can be unilateral, and it may sometimes extend to involve the thighs. Doesn't respond to antibiotic. Chronic lipodermatosclerosis follows either a thrombotic episode or recurrent cellulitis, or both, and results in the champagne bottle leg, that is to say narrowing of the ankle, which is fibrosed. There's often other signs of venous disease such as hyperpigmentation, dyspigmentation, atrophy blanche. Varicose veins may or may not be present. Contact dermatitis. So we see people with acute contact dermatitis that results in red, swollen skin. For example, somebody might be allergic to a strapping, which is adhesive, following an injury that broke the skin. So the broken skin could be a reason for infection, hence the prescription of antibiotics. But what we're really seeing is dermatitis. So how do we tell the difference? Well, dermatitis involves the epidermis. So there is blistering acutely and dryness subsequently. It can be a bit difficult to tell the difference because a bad, good-going cellulitis can also blister, particularly the variant known as erysipelas, which is a more superficial form of skin infection. But if you run your hand across the skin and it feels rough, think of dermatitis and ask about the contact factors. Dermatitis is very common in venous disease as well and can be unilateral or bilateral. There are many other conditions that can be confused with cellulitis, so I would refer you to our differential diagnosis of cellulitis page, which I think has another name, red legs, for many ideas when presented with a patient who's not responding to antibiotic.
I've linked to the Dermnet page in the show notes. There are a number of conditions to think about, the most significant being necrotizing fasciitis. But herpes zoster and superficial thrombophlebitis are all things I've seen recently that mimic to cellulitis, and there are other rarer conditions too, so it's worth having a read through the whole page. My take-home from both talking to Justin Morgenstern and Amanda Oakley is that cellulitis is very rarely bilateral and does not itch. So if either of these are present, and particularly if they've not responded to antibiotic therapy, I will be thinking, what else could this be? These are often cases that are worth involving more than one pair of eyes, so either asking a colleague to have a look, or if you have a teledermatology service in your area, sending a dermatologist a picture for a second opinion is always a good option. My thanks to Amanda for talking with our podcast. If you have any comments, questions, corrections or suggestions, please email podcast@rnzcuc.org.nz or visit our Facebook or Twitter pages and comment there. We'll be back again next week with another podcast. I look forward to seeing you all then, but for now, thanks for listening.